71 members are there. So till last class we were seeing malaria. Now I am starting another class on amoebiasis, anti-amoebic drugs. So you are head of amoebic dysentery, Amoeba histolytica, etc. So this amoebiasis so it is caused by the protozoa, that is Amoeba histolytica, and it is endemic in most part of India. And you know that it is because of this condition occurs. It is because of the poor environmental sanitation, and it occurs usually in the low socioeconomic status people. And because of the fecal contamination of you can see all these dirty things they are doing. So fecal contamination of food and water. That is the main reason. It is caused by Amoeba histolytica. And before going into the drug, anti-anemic drugs, we'll just have we will see what is the life cycle of this Amoeba. So usually it is transmitted through the cyst, Amoeba histolytica systole, by the contaminated. When we are taking contaminated food or water, it will come to our stomach, but it can resist the gastric pH, and it will come to the intestine. So in the intestine, it may there are different stages. I mean, it can either remain attached to the mucosa, or before that, if the cyst will be like this, cyst undergoes encystment and causes liberation of trophocytes. And these trophocytes, either it can remain in here, or it can form another encystment and form another cyst, which will be passed through from the intestine. It will be passed out. So there will be asymptomatic cyst passes, or it can remain here and cause ulceration. Histolytica means it will lyse the tissues, so it causes ulcers. And afterwards, these trophocytes can also enter the bloodstream, and it can cause extra-intestinal amoebiasis. It may go either to lung, liver, or it can even up to brain. It can go. So cyst, it is coming here. Trophocytes are liberated. It can make either cyst, it will be passed out, or it can remain like that in the intestine, and it causes just amoebic dysentery and the passage of blood and mucus, that is by the lysing of the tissues, or it may spread through the blood, and it can cause extra-intestinal amoebiasis, hepatic this abscess, amoebic abscess, amoeboma, etc. can occur in the liver, lungs, and brain. Brain, it is rare only, but it can happen because it is passing through the blood. So this is the life cycle. So same thing. So again, what I was telling, it reaches the intestine and form trophocytes, and it may form cyst. It can remain. It will be passed out or invade the mucosa and cause the amoebic ulcers and acute dysentery. Dysentery means passage of blood and mucus. It is not just a diarrhea. Diarrhea with blood and mucus in the stool, that is called acute dysentery. Or it can cause intestinal amoebiasis, that is inside the intestine itself. Chronic amoebiasis, it can cause vague abdominal symptoms and amoeboma, or it can pass through the bloodstream. It may reach liver via the portal vein and cause amoebic liver abscess. Also lung, spleen, kidney, brain, these are all rarely involved. And in the tissues, the trophocytes are present. The cysts are formed only in the intestine, and in the tissues, the only trophocytes are present. And chronic cyst passes will be always asymptomatic. They will be just they are carriers, and they will be passing the cyst, and they are not symptomatic. Then one important point is that in the colonic lumen, this Amoeba live in symbiotic relationship with bacteria. So it is in connection, it is attached to the bacteria, and it is living in relationship with that bacteria. So if you are killing the bacteria, that also can kill the Amoeba. That is one important point of Amoeba history. That is the life history. And there is a plant called Brazil root or Brazil root. It is a Cephalix epicaquana. So this is from this root one drug called emitin. It was obtained from this root of this plant, and that was used till 1960. This was taken as the anti-amoebic drug, but later on new drugs were developed and safe and less toxic drugs were developed. So now emitin, it is there still, but it is not used routinely. Rarely only used. Only those conditions where the patients are not sensitive to other drugs, we can go for emitin because it is highly emitogenic. So emitin, the word itself says it causes severe vomiting. So these are the anti-amoebic drugs. So the tissue amoebicide, it is there, and luminal amoebicide. So in the lumen, I told you there will be trophozoites may be there as well as the cyst will be there. And the tissues, it will be trophozoites. So tissue amoebicides, they are for the intestinal and extra-intestinal amoebiasis. The drugs used are intestinal, that is intestinal trophozoites, as well as extra-intestinal, liver, lung, brain, etc. The drugs are nitroimidazoles and alkaloid. Nitroimidazoles are metronidazole, tinidazole, secnidazole, ornidazole, and cetronidazole. Most important, metronidazole, tinidazole. Then alkaloid, emitin, dehydroemitin. And for the extra-intestinal amoebiasis, chloroquine. Chloroquine we have already studied in malaria, and this is useful in case of extra-intestinal amoebicide, not in the intestinal, extra-intestinal. Now, luminal amoebicide. These drugs will not be effective for other tissue amoebiasis. So the drugs are amides like diloxanide furovate, nitazoxanide, then antibiotics like tetracycline paromomycin, 8-hydroxyquinones like quinidochlor, that is idochlorhydroxyquine, and diiodohydroxyquine, that is idoquinol. So these are the drugs, and today we will be seeing this metronidazole and other related drugs, emitin, chloroquine, etc. So these are the anti-amoebic drugs. Most important, metronidazole, tinidazole, and this one, diloxanide furovate. Like primaquine, it was given for the radical cure of malaria. Diloxanide furovate, it is given after this metronidazole treatment. This is for the radical cure because it is effective against the cyst. So the cyst, that is the main agent that is for the transmission. So that will be destroyed by the diloxanide furovate. So first we will be giving metronidazole, then followed by diloxanide furovate. Okay, we will see one by one. So one is nitroimidazoles or metronidazole. This metronidazole, it was first introduced for the infection trichomoniasis, but later on it was found out that it is useful for amoebiasis also. So it is having a lot of action. One, it is effective against the this amoeba, and also it is effective against, already we have seen it is effective against trichomoniasis. Then Giardia lamblia, giardiasis, and also some anaerobic bacteria like Bacteroides fragilis, Fusobacterium, Clostridium perfringens, Clostridium difficile, Helicobacter pylori, which causes the peptic ulcer, Campylobacter, Peptostreptococci, spirochetes, anaerobic streptococci, etc. will be sensitive. So out of this, you have seen Bacteroides fragilis, it is an anaerobic bacteria. Then Clostridium difficile is the one which causes pseudomembranous enterocolitis, and Helicobacter pylori, it is important in case of peptic ulcer. So these conditions, we will, when come to uses, we will see that this metronidazole, it is effective in such conditions. So it is one of the drug for anaerobic infections also. But it does not affect aerobic bacteria. We will see what is the reason. So metronidazole, it is not useful for aerobic bacteria. So for that, we have to understand the mechanism of action. First, I will describe the mechanism, then I will explain everything. So what does this is a mechanism of action? We first read it out. So metronidazole is selectively toxic to anaerobic and microaerophilic microorganisms, not to aerobic, only anaerobic and microaerophilic. After entering the cell by diffusion, nitro group is reduced by certain redox proteins operating only in the anaerobic microbes. So this is present only in the anaerobic microbes to highly reactive nitro radical, which exerts the cytotoxicity. So this redox proteins, they are present only in the anaerobic microbes. That means this nitro radical can be reduced only in anaerobic microbes because of the redox proteins. Then what happens? So it is converted to some highly reactive nitro radical. Then now we will stay like that. Now in the anaerobic organism, there is another enzyme called pyruvate ferredoxin oxidorreductase enzyme, or PF4 enzyme. This enzyme is responsible for the liberation of certain electrons in the organism. These electrons are actually needed for the energy metabolism of anaerobes. So what this nitro radical, what they do, this highly reactive nitro radical, it will act as an electron sink, and it will receive all the electrons. It will accept all the electrons that is liberated by this PF4 enzyme. So it acts as an electron sink. So for the energy metabolism of anaerobes, there are no electrons. So they are dying. So that is what. So first in nitro group, it is converted. It is reduced to a highly reactive nitro radical. This will act as an electron sink, which will receive or accept all the electrons that is generated by PF4 enzyme pathway. So this is these electrons are actually needed for the anaerobes, but that is they are not getting, so it will cause the death. So now we will see the picture. So I was telling aerobic environment, this is not effective, or aerobic bacteria, metronidazole are not effective. Why? Because there is no reduction. So the aerobic environment attenuates the cytotoxicity by inhibiting its reductive activity. So only the reduced nitro radical can act as an electron sink. That is number one. Number two, this oxygen, because aerobic, they will be surviving in the presence of oxygen. So this oxygen, it will compete with the nitro radical and of the metronidazole. And so it is competing with the nitro radical, means now the nitro radical cannot accept the electrons that are generated by the anaerobes. Okay. So there are two reasons. One, there is no reductive activation. Now second, the oxygen that is in the environment, that aerobic bacteria, it lives in the aerobic or environment with oxygen. So that oxygen will compete with the nitro radical. So because of the two reasons, this metronidazole, it cannot be used for aerobic bacteria. Now we will see just the picture. So this metronidazole, it is converted to a reactive nitro radical. So this reduced to highly reactive nitro radical, it will compete with the biological electron the electron acceptor. That is, it acts as an electron sink. So it accepts all the electrons that is produced by the PF4 enzyme pathway, and so the energy metabolism of the anaerobes, it is actually disrupted. So because of that, again same thing. So it is aerobic and reduced in 5-nitro position, and it causes it reacts to the DNA and other micromolecules, and that causes the cell death. Especially because of the energy metabolism, it is disrupted. Because of that, the death of the anaerobes, it occurs. So that was the metronidazole mechanism of action. And some other actions of metronidazole, it also inhibit the cell-mediated immunity. It can cause mutagenesis and radiosensitization. So because of the mutagenesis, we cannot use in pregnant people also. Now about the pharmacokinetics, you know that I think you would have seen, and some people would have used it also for your, if you are developing some dysentery or something, we will use this metronidazole, and some other conditions also we will use metronidazole, like trichomoniasis, giardiasis, etc. So metronidazole, usually it is given orally. IV preparation, IM preparations are also there, and it is well distributed in the body. So oral tablets are there, and also parenteral preparations are there. Now, what are the adverse effects? Adverse effects, it is only mild, but one adverse effect is metallic taste. So if you take the metronidazole, we will get a metallic taste in the mouth. That is one important adverse effect of this metronidazole. And other less frequent, it is headache can occur, glossitis, dryness, allergy can sometimes urticaria, Then peripheral neuropathy can occur, and seizures sometimes occurs in high doses. And another important adverse effect is thrombophlebitis. If it is given parenterally, it can cause some thrombophlebitis. That is, thrombophlebitis means inflammation of the vein. So it can cause. So the first and foremost, it is the metallic taste, but it is not that serious. But the patients will be having that, developing that metallic taste when they are taking oral tablet. Now, contraindications. So, it is contraindicated. I told you it cannot be used in the pregnancy. So, first trimester pregnancy we cannot use. Blood dyscrasias, neurological disorders, it is contraindicated. And another thing, it is chronic alcoholics. But in alcoholics, there is a condition called disulfiram-like reaction, disulfiram-like intolerance. See, what is this disulfiram? You will, when you come to alcohol, the chapter you will study disulfiram. Disulfiram is a drug that is used for the de-addiction of this alcohol de-addiction. So in people with alcoholism, we will usually I'm just talking about alcohol now. So ethanol means it is alcohol. Usually ethanol, it is converted to acetaldehyde by alcohol dehydrogenase, and this acetaldehyde is converted to acetate by aldehyde dehydrogenase, and this will be excreted out. So this is the usual the metabolism of ethanol. So the people who are alcoholic, so what we are doing, we will give one drug called disulfiram. Disulfiram, it will inhibit this enzyme, aldehyde dehydrogenase enzyme. So there will be, this conversion is not happening, acetaldehyde to acetate. So only acetaldehyde, large amount of acetaldehyde will be formed. If there is lot of acetaldehyde in the body, what will happen? The patient will develop nausea, vomiting, palpitation, blurred vision, dyspnea, etc. So suppose in a patient who is alcoholic, if you are giving disulfiram, in their body, lot of acetaldehyde will be formed, and immediately on taking alcohol, and already he is on disulfiram, and if he is taking alcohol, then he develop nausea, vomiting, palpitation, etc. Then so next time when he sees alcohol itself, he will be feeling that all these intolerable and unpleasant feelings. So by that, the addiction can be removed. That is the mechanism of using disulfiram in alcohol addicts. Same thing occurs if you are taking metronidazole. Same. This metronidazole also can cause the inhibition of aldehyde dehydrogenase. So as a result, there will be extra acetaldehyde. So the patient, if he is an alcoholic and he is taking metronidazole, he can develop a disulfiram-like intolerance. So I think you understood that intolerance. So in patients who are on alcohol, suppose they develop, the alcoholic patients, if they develop dysentery, try to avoid, or you can tell them such thing can happen, but it is seen that it may not occur in all alcoholic patients. It is there is also variation. So some people, most of the people will be developing, but some people they may not develop also. So that is also there. But you can warn them that is this thing can occur. If it happens, then we have to stop it and come back. Okay. So that is the interaction. Now we will see the uses. Uses we have seen, it is mainly used for the dysentery. Which all dysentery? It is there. There are intestinal disease. It is there. Then amoebic dysentery and liver abscess will be there, and invasive dysentery, liver abscess. Okay. So there is intestinal disease as well as extra-intestinal disease. Amoebiasis, it is there. For invasive dysentery, that is extra-intestinal and liver abscess, usually we will give 800 milligram TDS for 7 to 10 days. And if it is severe amoebic dysentery, liver abscess, even we can go for intravenous also. 500 milligrams IV slowly every 6 to 8 hours for 7 to 10 days. Both it is given 7 to 10 days, or till oral therapy can be given. We can give for some 3-4 days IV, then later on we can change to 800 milligram TDS like that. But if it is just a mild intestinal disease, so we are just developing dysentery with blood and mucus, there is no extra intestinal spread, then we can go for 400 milligram 3 times for 5 to 7 days. So this is the use. And this metronidazole having many other uses also, we will see that. So it is used in giardiasis. If you can remember this thing, the dose, it is okay. 400 milligram, 3 days for TDS for 7 days. So giardiasis, trichomonas vaginalis. So here trichomonas vaginalis, it is a 2 gram single dose. Okay. And in addition, we have to give some intravaginal because trichomonas, it is vaginitis. Trichomonas vaginalis, the agent causing trichomonas vaginitis. So vaginitis means intravaginal treatment, some ointments, pessaries, etc. can be also kept for treating this trichomonas vaginitis. Then metronidazole also used for because it is effective against many anaerobic bacterial infections. And but usually when we give, it will be given along with gentamicin or cephalosporin because anaerobic bacterial infection alone usually as a single infection, that is only anaerobic bacterial infection usually won't occur. There is always a mixture of aerobic as well as anaerobic bacterial infection. So that is why we are combining cephalosporin or gentamicin. Then it is also used for pseudomembranous enterocolitis because it is effective against Clostridium difficile. Clostridium difficile it causes pseudomembranous enterocolitis. It is a super infection. So metronidazole, how much it is given? Again, 400 to 800 milligram BD or TDS for 10 to 14 days. So it is convenient as less toxic. So that is the pseudomembranous enterocolitis. Which is the other drug for pseudomembranous enterocolitis? Amoebiasis. Amoebiasis. Amoebiasis, are you there? Amoebiasis.
Yes, ma'am. Yes, ma'am.
Do you know which is the other drug for pseudomembranous enterocolitis?
Don't know, ma'am.
You don't know. Anyone in the class?
Vancomycin.
Who said vancomycin?
Sanjeev.
Saji, very good. And Sri Lakshmi also told, I think. Is it so?
Yes, ma'am.
Yes,
Ma'am.
Yes. So two drugs are there, oral metronidazole or vancomycin. Other drugs are also there. At least you remember these two drugs. So for pseudomembranous enterocolitis, metronidazole and vancomycin. So metronidazole, now we are dealing with metronidazole. So it is 400 milligram to 800 milligram BD or TDS for 10 to 14 days. As you know, pseudomembranous enterocolitis is a highly fatal. Fatal means we are not stopping the drug because of the super infection with certain drugs like any antibiotic. It can cause, if you are giving for a long time or a high dose if you are giving, it can develop enterocolitis and there will be the mucosa, there will be, it will be removed. So there will be blood and, bloody diarrhea will be there. So if you are not stopping the drug, this will continue and patient may die also. So it is a very serious condition. So such cases we have to stop the drug, give metronidazole 400 or 800 milligram BD or TDS depending upon the seriousness for 10 to 14 days. Then acute necrotizing ulcerative gingivitis. Acute necrotizing ulcerative gingivitis. Amoebiasis. Amoebiasis.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Where are you going?
Nowhere, ma'am. Yes, ma'am.
Okay. What gingivitis means? Which organ, which part of our body is affected?
Sorry, ma'am.
There is this metronidazole. It is used in acute necrotizing ulcerative gingivitis. So gingivitis, it is which part of our body?
Gums.
Yes. So there will be ulceration in the gum, that is ulceration, inflammation as well as ulceration in the gum. So that is called anug or trench mouth. It is also called trench mouth. Here also we can use this metronidazole, and it is caused by some anaerobes like fusobacteria, then spirochetes and bacteroids. So this is metronidazole, it is given. Again, dose, if you can remember, no problem, 200 to 400 milligram 3 times daily, and usually it is combined with amoxicillin, tetracycline or erythromycin, because in our mouth, not only anaerobes, other things also will be there. Aerobic bacteria also will be there, so we are combining these drugs. So acute necrotizing ulcerative gingivitis. Then one more condition where metronidazole it is used is helicobacter, this peptic ulcer. Peptic ulcer, one of the bacteria, we have found out that H. pylori is one agent that is responsible for the peptic ulcer. So for this also we are giving metronidazole. Another related drug, it is tinidazole. So you can see this is a H. pylori kit. Each kit contains, you can see this lansoprazole, clarithromycin, tinidazole. Tinidazole, it is another related drug of this, another nitroamidazoles. So some cases it will be metronidazole, and because it is less side effect, so tinidazole is used. So you can use in case of H. pylori treatment. That's it is a triple drug regimen for H. pylori. So this metronidazole, it is used for the H. pylori peptic ulcer. Sorry. So once again, I'll show you the uses. So we are using metronidazole for amoebiasis, number 1. It may be mild intestinal or invasive extraintestinal amoebiasis, liver abscess. It is used for giardiasis. It is used for trichomonas vaginitis. Then anaerobic bacterial infections, pseudomembranous enterocolitis caused by Clostridium difficile. Then acute necrotizing ulcerative gingivitis, or it is called trench mouth, and peptic ulcer caused by Helicobacter pylori. So that is that means usually it is in the chronic stage. We will give for the eradication of sorry, Helicobacter pylori. So anti-H. pylori treatment. It is a triple regimen we are using. Now we will go to other drugs. I mean, it is other nitroamidazoles. First we are seeing metronidazole. For this also there is not much points. Tinidazole, it is again a container of metronidazole. And metronidazole, the THAF was 8 hours, but here it's only, here it is 12 hours. So duration of action, it is longer. So we can go for metronidazole. We have seen we are giving BD or 3 times daily, but this can be given once daily therapy. And this in tinidazole, it is better tolerated, and side effects it is lower. That is why in the kit also I have shown here it is tinidazole. It is less side effect. So tinidazole, then other related drug. The recommended schedule. So tinidazole, see, you can see everything 2 gram. Intestinal amoebiasis 2 gram oral. Amoebic liver abscess also 2 gram oral. That is for 6 to 12 days it will be. Trichomoniasis, giardiasis, etc. 2 gram. And also other anaerobic bacterial infections. So like metronidazole, it is used for amoebiasis, trichomoniasis, giardiasis, anaerobes, H. pylori, everything it is used. So that was tinidazole. Now next is sechinidazole. Sechinidazole, it is the longest acting it compared to other nitroamidazoles. This is longer action, 18 to 24 hours. So it is the longest nitroamidazole. Same uses, same spectrum of activity, everything. Like that, ornidazole. So tinidazole is there, tinidazole, then sechinidazole, it is the longest acting. Then ornidazole, that is also longer acting compared to this metronidazole. Then cetronidazole. Compared to others, it is again very low side effect. It is better tolerability, minimal nausea, vomiting, metallic taste. I told you if you are taking metronidazole, there will be metallic taste. It is not there. Absence of neurological side effect and the disulfiram-like reactions. It is also not there with ceftriaxone. So ceftriaxone is somewhat the safest. I mean the adverse effect wise. So once again the drug names, first one was metronidazole, then tindazole, sectinidazole, which is a longest acting, ornidazole, and ceftriaxone. Now coming to the next drug, that is emitin. Emitin, I told you, it is obtained from the Brazil root, that is Cephalus ipecacuana, this plant. And it is its mechanism actually, it is like other antibacterial, it inhibits the protein synthesis. That is, inhibits the translocation of tRNA, translocation in the protein synthesis, translocation, that step it is inhibited by emitin. But the problem is it is highly emitogenic. So it is kept as a reserve drug only, and now only it is rarely used. When the other drugs are not effective, we will go for emitin. Otherwise, it is not used nowadays because we have other safe and less side effect drugs. Then another derivative, it is dihydroemitin. It is less toxic compared to the less emitogenic and less cumulative, etc. compared to emitin. So that was about emitin. Then next drug is chloroquine. We have already studied everything about chloroquine when we studied this malaria. This also kills the trophozoites of Amoebiasis I, but it is used only for hepatic amoebiasis. It is not for that is in the intestinal amoebiasis we cannot use. It's only for the extraintestinal hepatic amoebiasis. So extraintestinal amoebiasis we can give chloroquine. It will be continued. I am stopping it here. One more class will be there for amoebiasis. Okay.